Okay, so hello, good evening, everybody. I hope you can hear me well. I would like to welcome you for this online webinar, in which in the next hour we are going to discuss some clinical concepts related to the restoration and soft tissue interface, both on teeth and implants. So as you can see from the background, for the moment I can't see myself, but I'm still in the office after a day of work. And I hope we will have a nice and pleasant 1 hour all together. Before starting, I would like to thank Dental Tribune and MIS for the opportunity given for us to be together today. So basically, in the next hour, the presentation is divided into two parts. So we will discuss a little bit about the cervical contours of our restorations, some aspects regarding the profiles, when you talk about natural dentition. And in the second part, we will concentrate more on how we contour our restorations related to the soft tissues, and also some aspects related to the importance of the soft tissues when we talk about implant-supported restoration. So basically, the lecture will be emphasizing one clinical concept that is related to the cervical design. And as you can see on the left side of the screen, it will relate to also some technical part of the workflow that the dental technicians are providing for us, and it has a clinical impact on the final outcome, of course. And each part is going to have one clinical case that will be representative, and it will actually emphasize the complete workflow. Now, some aspects about my background. I was born and raised, and I graduated my studies in Romania, in Timișoara. That was around almost 13 years ago now. And for the last 9, almost 10 years, I'm having the privilege and the opportunity to be with a wonderful team in Tel Aviv, together with Professor Litzan Bichacho, whom I guess many of you know very well, and my colleague, Dr. Galit Dalmor. So let's get started. So the first part will be dedicated to natural dentition, and let's go and see some of the concepts that are important to apply. So regardless of the treatment plan that we are choosing, we have certain steps that are important to be followed rigorously, which is always starts with the data collection. And it usually involves some information regarding the history of the patient, some clinical data, dental x-rays, clinical images, and some videos. That is being followed by the communication step, which is a very important part, to which I guess the final success also relies to. It is understanding actually the expectations of our patients, if these are something that we can fulfill, and also the communication with our dental technician, with the laboratory, and all together be able to move forward to creating a specific design of the final outcome. Now, different ways to go for that, different ways to create the so-called mock-ups. We will not go into details tonight, but actually they all emphasize the final aesthetic result, having function and biology in mind, of course. So Dr. Jaime Gill used to say that when you don't know where you're going, you can't get lost. So actually, we definitely, in our treatment segments, we would like to know from the beginning what will be the final result that we would like to provide for our patients. So having the end result in mind is crucial. So we will always start with an aesthetic analysis, knowing from an aesthetic point of view what is the final form, shape, and positions of the future restoration that we would like to have. According to that, we are going to analyze some aspects regarding the structure and see if the project, the aesthetic project that we planned, is something that can be fulfilled. And definitely aiming for a biological integration of all the structures and the components. So we have a first phase, which is the control, and this involves the non-surgical periodontal treatments, all the caries that are present, and odontical treatments, so practically a structural analysis of the entire oral cavity, and this will be followed by a reevaluation. In the second phase, so-called the corrective one, in which provisionals will be inserted, different specialties that are needed will be involved in the treatment planning, such as orthodontics or surgical periodontal steps that need to be performed, bone and soft tissue corrections, implants will be inserted also at this stage. At the end of the second phase, we have again a re-evaluation. And this is important because, as we know, many things can change during the treatment, and some aspects regarding the prognosis of certain teeth can change. The third phase, the rehabilitation, relies on actually stabilization of the entire oral cavity, the entire structures. Refinements are performed if needed, and a prosthetic workflow is being finalized. And that involves the definitive restorations. And last but not least, a very important phase, which is the maintenance, to which actually depends the long-term results of whatever we performed clinically. So we are trying to aim for an integration, but a harmonious integration between our cervical parts of our restorations and the soft tissue margins. And this is a very sensitive area where we would like to obtain this natural and biologic integration of the structures, not only when we talk about natural dentitions, but also when we have implants as the base for our ceramics. So we aim for longevity of our clinical results. And in order to achieve that, we have certain steps that we need to follow rigorously. For example, we know that we can guide and we should guide our preparations in terms of to have a control in the amount of tooth structure that we remove during the preparation phase. So, for example, as we can see in this clip, as Dr. Galib Gurel showed us, if we prepare through the final position of the future restorations, we will remove only the amount of tooth structure necessary in order for the dental technician to be able to create those ceramic restorations. So we will be very minimally invasive with our preparation design and conserving as much as possible the enamel. Moving forward, then we will have to transmit this information to our laboratory, to the dental technician. And now, regardless of the type of workflow that we are going for, a digital or still an analog way, we still have to follow certain steps like deflection of the soft tissues using retraction cords. We still need to know how to properly choose them in order not to cause any damage to the periodontal structures. And then, of course, following correct protocols when it comes to the adhesion. And that depends, of course, if we have only enamel, if we have a combination of enamel and dentin, or sometimes even composite restoration. And when it comes not only to the conditioning of the tooth structure, but also of our ceramic restorations. So basically, we need to follow rigorously the protocols for each and every step. Now, when we see such a clinical situation of an anterior dentition, obviously there are several factors that are not in line with our aesthetic concepts and I guess also with expectations of such patient. So obviously an improvement from an aesthetic point of view will not be such a big challenge, given the starting point that we have. But as we can see, there is some biological implication. We see soft tissues that are in sufferance. We see lack of adaptation between the crown margins, most probably with some overhanging, and soft tissues basically that are in suffering. This discrepancy and lack of harmony becomes even more prominent when we look at the smile of such a patient. So in terms of the sequence of planning, things will not be so easy. We will have to redo our endodontic treatments. We have to redesign the preparations. We will provisionalize the patient for long-term provisionals because this type of treatments, it takes time until we see that we are able to obtain soft tissue health. Then we are going to reevaluate and determine what will be the prognosis of each abutment and then perform again a reevaluation. So what exactly we did, as we can see in this image, these were the wide preparations that we found at the time that we removed the old ceramic crowns. So we changed the design of the preparation from something pretty wide into more narrow. By doing that, we also gain space, as we can see here, in between the sorry for that. Let's see, go again. In between the prepared teeth. So we will get health for the soft tissues back. So these were the redesigned prepared teeth with a very light chamfer preparation design. And then, as I said, we provisionalize the patient, and this stage is important not only to analyze changes in the soft tissue health, but also to understand if the final aesthetic result is something that the patient is pleased with. And only once we get the approval of the patients regarding the shape, the position, the form of the future ceramic restorations, we are moving towards the definitive. And then the work is pretty simple and also predictable, because we are just copying already a design that we test drive together with our patient. So we make our lives and our dental technicians' life much more easier. So as you can see, it is obviously an improve, not only from an aesthetic point, but also from a biological aspect. So we were able to regain the health of those soft tissues that we can see clinically. And these were the beautiful restorations that Giuseppe Romeo provided for us. This is 1 year post-op. Definitely when we are encountering clinical situations that are more demanding, where the deficiencies are even more complex, as we can see here, then definitely the treatment itself will be more challenging. So in order to get to such a final result, as we can see in this image, we went through different steps again. So it's important to follow specific protocols and not to step in between phases. So we always start, as I mentioned, with the preliminary aesthetic analysis. So we would like to know what we would like to achieve from an aesthetic point of view for our patient. Then this specific case, she went through initial therapy. She received her first set of provisionals. Then we addressed any periodontal problems. Crown lengthening was performed in the eruptive number 12. And then we waited for around 6 months. So as we can see, it is a treatment that will take not weeks, it's a matter of months, because for soft tissue maturation, we definitely need to wait. Then we perform a reevaluation. A second set of provisionals will be inserted in this case in order to finalize all the aspects regarding the final aesthetics for the patient, and then we will continue with the final restoration. And again, because we would like to have not only an aesthetic integration, but a functional and, more important, a biologic integration of the different interfaces, and to see this type of response of the soft tissues to whatever we have performed before clinically. Now, when we look at these smiles, and we notice that there is a very nice harmony of the ceramic restoration related to the frame, which are the lips. And we can see that each and one of them has undergone for more simple or more complex restorative treatment with different type of deficiencies. But when we take a closer look at actually how intraorally, what strikes us to the eye is this natural blending and harmonious integration, especially when it comes to the cervical part between the margins of our ceramic restoration and the soft tissues. So in order to have such a harmonious integration, it's important to understand a little bit about the profiles and angles of our ceramic restoration related to the tooth structure or to the prepared teeth. So when we talk about this relationship, we have an emergence angle, which usually is defined by the continuation of the root and the cervical part of our restoration, and it can have a specific number. When we talk about cervical profile, though, we talk about this part of our ceramic restoration that can have different aspects. It can be more over-contoured, it can be more flat, as we can see here, and later on we will understand what is actually the impact of such a design when it comes to the soft tissue. So even more striking to the eye is that we can have at the same emergence angle a different type of cervical profile. So clinically, we are going to relate much more to the cervical profile of a specific restoration in relationship with the soft tissues. About this type of concepts. Nitzan has published already in 1994, and he called it the cervical contouring concept when it comes to the dentogingival complex. And what he defined actually is two main areas. He described it as pressure absorbing zones, which, as you can see here, they are the intraproximal areas, that is defined with number 1 and 2. So interproximally, he described that we actually can compress more the soft tissues because they could adapt to the clinical change. And there are areas like the pressure relief zones where our contours of our restoration will better stay less over contoured and more flat. And we are going to see that this also depends on the soft tissue biotype. One very obvious example in order to explain better this type of concept is when we look at space dentitions. And as we can see, this was a pretty young girl that she wanted to close the spaces between her anterior teeth. And on the left side, we have the preoperative situation, and on the right side, these are only the prepared teeth. So we can see we're pretty minimally invasive in the amount of tooth structure that we removed. It was only a light chamfer design type of preparation that related only to the cervical part and the interproximally. Now, what is important is to understand that when we perform this type of cases is that one thing for sure, we will not like to end up with black triangles, meaning that closing of the gaps will have to be done properly. So the dental technician, in order to be able to give a proper contour to the ceramic restorations, needs to have a correct preparation design and also a correct position of this preparation related to the tissues. Meaning that we are going to place our preparation slightly intraclavicular in order for a dental technician to have enough space to build a correct cervical profile that will give support for the tissues in this part. And as we can see, slightly as we go to the mid-cervical part, we are more superficial with our positioning our preparations margin. So as we can see, these are the veneers that Vincenzo provided for us with a very nice relationship within the soft tissues. So the biologic response to whatever that we do intraorally, it actually depends on the thickness of the connective tissues that we have between the two epithelial layers. And I'm referred to the oral epithelium and the intrasulcular epithelium that you can see in this image. What do I mean? And these slides are courtesy of Professor Portoriero, but they emphasize very nicely also from a histologic point of view what we actually see clinically. So if we take a look and we try to understand what exactly is happening when we are inserting a crown that has an improper cervical design or cervical profile. So as I mentioned, there is the connective tissue that we have between the two epithelial layers, and if this would be the width and this would be the height, and we are going to have a ceramic restoration that is slightly over contour. So the first thing that is going to happen, we will see the blanching intraorally, and the blanching, that's actually a vascular response, meaning that ischemia is being triggered in that area. Now, at this point, the tissues have actually two main options. So accordingly to the amount of connective tissue present, they can either adapt to this, you can call it iatrogenic factor, to the new design of our ceramic restoration, and if the thickness is sufficient, they will be able to regain vascularizations from the surroundings. In the case that that is not happen, like in thin biotypes, then they will not be able to regain vascularization at the same position, so they will have to move more apically where they will find the blood supply. So what happens in that particular margin, we will have thrombosis, we'll have a septic necrosis, and what we are going to see clinically, actually, if we look from the profile, and this is our restorations with the slightly over contour profile, so we see the blanching, we see the ischemia, and in time, the soft tissues actually migrate more apically, and we see a marginal recession. So this is the clinical consequence of having contours of ceramic restorations that are not in line, let's say, with biology of the supporting tissues. Just a very short example. These were two central incisors that we restored. At the time that we tried endoceramic restoration, we saw that we have different positions of the soft tissue margins between tooth number 11 and 21. So we would like to slightly create the same contour, more accentuated on the distal part, to be similar to the tooth number 21. So how do we do that? We just slightly increase the contour, and again, this is possible only in the situation that we know that the soft tissue will be able to adapt and not to cause any irreversible changes in the positions of the soft tissue margins. So we understood that there is a correlation between the shape, specific shape, the cervical profile of our restorations and the preparation in terms of the design, which type of preparation, and also the position of the preparation related to the soft tissues. And in order to emphasize what I just previously described until now, I will share with you a pretty interesting case. It was actually we were pretty lucky, I guess. Nitsan always likes to say that about the result, because when the lady presented herself to the office, she said she would like to improve her appearance, but she wouldn't like to go through any kind of surgical interventions. So just by looking at the images and performing all our data analysis, we understood that we are dealing actually with a pretty challenging case, because she had a high lip line, so it was very visible when she was smiling, the cervical part, and we have a pretty obvious discrepancies in terms of the positions of the soft tissue margins between the right and the left hand side, and also in terms of the contours. And Nitsan said, well, we should try to do maybe some crown lengthening, and the patient will completely insisted that if it's possible to obtain, even if it would be a compromise, but try to find a solution that will be only by prosthetic means. So we went through our data analysis, and we decided, first of all, try to understand if we need to lengthen these teeth, in which direction. So we went through all the usual aesthetic analysis. So we decided that actually we will have to lengthen these teeth in a coronal way, regains function, the canine and anterior guidance for the patient. But when it comes to our main problem regarding the discrepancies of the soft tissues, well, this will be more or less the design that we would like to have. But then what will we do with the soft tissue position between especially tooth number 21 and 22? So if this would be the outline, let's say, of the future ceramic restorations, we started to analyze how would the contours of this restoration should look like if we would like to aim for a change in the position of the tissues related to these future restorations. So we had some areas that we will have to slightly over contour, and we will have some, like we can see here in the mesial part of tooth number 21 and also on the tooth number 12, in order to balance the initial discrepancy. And some other areas, they will try to stay as flat as possible. So if we have the design, more or less, of the final result, and we establish the problems, according to that, we are going to establish how we are going to prepare these teeth, which areas we will have to go more interproximally and adapt the concept similar to space dentition, for example. And all this information, by the way, is also transmitted to the dental technician, because he will need to understand exactly what do we expect in terms of the final design. And as everything, we perform initial wax up to see if the compromise that we will aim for will be something that will be sufficient for our patient. So if she will be pleased with the final aesthetic result. So we understood that this will not be a perfect situation at the end. This is actually with the mock-up that we performed that addressed the upper and lower teeth. And because of personal preferences, we started first to treat the first arch, and only later on we addressed the lower dentition. And the patient was pretty satisfied with the way that the mock-up presented, and she said that if this would be able to achieve also with the final ceramic restorations, she would be more than happy with the final result. And this is what we did. As we can see, these are already the prepared teeth, but we tried to stay away from the cervical part. So actually what we did, we removed the composite restorations and we just smoothened that area, and we redesigned and replaced the preparations in a more cervical part, especially of the tooth number 21 and 22, due to the initial planning as I just mentioned. Now, when we take a look from an occlusal aspect, we see that we were pretty minimally invasive in the amount of tooth structure we removed. We were managed to maintain the enamel almost entirely, also on the canine areas that were prepared for full contour crowns. And some areas where contact points were open and the approach as for the spaced incisions was applied. And as we remember, again, in those situations, dental technicians need to have sufficient space in order to properly build the contours of those ceramic restorations. And certain areas we maintain the contact present. This was the final result. This was 1 year post-op, and again, it is like we pre-visualized. We knew that we will try to let's say minimize the discrepancy, but it will not be something that would give us the perfect result. But what was very nice was the harmonious integration that we obtained, and it's even nicer to see this type of results. This is 4 years in function, and the patient as well as we are pretty happy with the final result, given the fact that we were able to follow her desires and her main concerns, which was not to have any type of surgical intervention involved. Now let's go through a clinical case briefly that will actually emphasize a complete workflow from the beginning till the finalization. So we have a complex deficient anterior restorations, as we can already see from the smile of our patient, and this is the intraoperative view of the anterior teeth. So there were several problems, not one, and aesthetics was, I guess, the last one for these patients, because as we can see, he has undergone several dental treatments in the past. So we see old composite restoration, all with infiltration, but we also see soft tissues that are not in complete health. He was not a very good cleaner as well. And we had also the discrepancies between the soft tissue margins in the area of tooth number 11 and 21. Now, because he didn't show this part when he was smiling, so soft tissue surgical procedure was not taken into consideration, but we were aiming for two things: to try not to increase the discrepancy during treatment planning, and if possible, at least optically, to mimic that we will have more or less the same appearance of the two central incisors when we bond the ceramic restorations. So we always try to understand what are actually the issues that we are dealing with. So we see that we have a combination of restoration that might impose a problem. We have color of the substrate, that will be for sure, and then how to design the cervical profile of the future restorations in order to try to balance and compensate the discrepancy present. And then according to our issues, we also should set up our goals, meaning what we would like to achieve. And the first thing that we have on our to-do list is to follow, first of all, the expectations of our patient. And he was pretty straightforward when he told us, well, I would like to improve the overall appearance, but I don't really want to change anything in my smile. So he didn't want people to notice that something has changed and that he has undergone a dental treatment. So we will have to maintain the shape, more or less, of the anterior teeth. We will try to rebalance the colors, the substrate colors, of course, and follow a minimal preparation procedure during the prosthetic steps. Now, we try to analyze our substrate before proceeding, and in order to replace all these old composite restoration. And a very useful tool in order to have a better understanding of the value, for example, of the natural dentition is to use a black and white picture that we can make it in a Keynote or take it directly with a camera, and a polarized image, as you can see here, with the masses of the composite on the teeth, that will give us a better understanding of how to choose the specific composite. So we go through the typical restorative phases. We are going to remove all the composite restorations, and at this stage it is important because we will get a better understanding from a structural point of view what is the prognosis of these future teeth, because according to the amount of healthy tooth structure that we have before replacing the composite, we will understand what type of ceramic restoration these teeth will receive. If it's going to be a veneer, a typical window approach, or a three-quarter veneer, or if it's going to be a full contour crown. So on the right side of the screen, we have the teeth after the composite restoration were replaced. And one aspect that is important also to notice is that we managed to bring the patients to very good compliance. So oral hygiene he was able to maintain his oral hygiene in very nicely. And until they are not able to proceed from this point of view, we are not going to proceed with the treatment. Then tooth number 11 has undergone a root canal treatment. So for the future restoration, we are going to have a full contour crown for 11, a veneer, three-quarter veneer, better to say, for 21, and then 12 and 22 will have a more type of classical window approach. Again, the main concern that the information that will be important to transmit to our dental technician will be regarding of the cervical profile of these restorations. Now, as we can see, these were already the prepared teeth. You see very nicely the different type of preparation designs according to the amount of healthy tooth structure that we had before we replaced those composite restoration. So we went for a typical window approach for the laterals, three-quarter and full crown. Now the decisions for the design and the correct profiles starts already from the model, already from the wax up. At this stage, the dental technician already knows and understands that he will have to have, for example, a completely different approach when he's designing the profile of the crown on tooth number 11, then he will have to do it on the veneer for tooth number 21. An important aspect is not only our precision and the time that we invest for a correct and accurate preparation, but is also the precision and fit of the future ceramic restoration. As you can see here very beautifully, not only the adaptation, but we see already, we can emphasize that there was a different approach when Stefano, in this case, built the ceramic restoration for these teeth. Now let's go more clinically and see actually what is the main difference. So if we take a look from the profile, and we have tooth number 11 that was prepared for a crown and tooth 21 for a veneer. So we have two main problems. First of all, we will have a color of the substrate that is different, and we will have also a different amount of tooth structure that was removed, meaning that the contours, the space that was given for Stefano to build his ceramic restoration is different. Second of all, we also, as I mentioned at the beginning, we don't want to increase even more the discrepancies between the soft tissue margins between the two centrals, so we will have to have a different approach when it comes to the design of those ceramic restorations. So as we can see, he started to build the contours in the area of tooth number 11 much more flat, starting very flat, very in a vertical almost direction, and then slightly build the ceramic similar with the veneer area, as we are going to see a little bit later on. And in the time of the insertion of the crown, this is what actually we can see. There is no blanching on the soft tissues because there is no compression, no pressure is going to be applied in this area. These are after the bonding of the ceramic restorations. We can see that optically he was able to create a similar appearance of the two central incisors. That was actually our goal. So starting very flat, that is also mimicking some kind of like a root recession. And then he is going to build and position the height of contours of these two ceramic restorations at the same position. And this is what actually gives us the optical illusion of having overall the same shape. So we provided for this patient also with two composite restorations in the area of the canine, and just to slightly modify the shape and to make the entire smile much more harmonious and pleasant to the eye. These were the 3 veneers and 1 crown. And I guess that we were pretty successful in maintaining our patient's wish, in keeping the same shape and arrangement also in the arch. As you can see, the different position between the laterals and the centrals, that Stefano was very nicely able to do that. And also a very good integration from a functional but also a biological perspective. Now, when we move to the implant side, actually the concept that I just described applies with some variation also for implant-supported restoration. And when we talk about optimal aesthetics around implants, we all agree, I guess, that we talk about a volume of tissues, and it can be hard tissues related more to the hard tissues or to the soft tissues. But we are talking about creating a certain volume. And for that, we are usually defining in terms of numbers that we need to have at least 3 millimeters buccally to the implant and around approximately 2 millimeters interproximally. So when we discuss about soft tissues, the most, let's say, common question that could arise would be, why should we graft? Why do we need a certain amount of volume, especially when we talk about soft tissues? And as Uli Grunder published already in 2011, although it was a limited time period, it was only during 6 months, because I guess in a longer period of time, when we know that soft tissue complete maturation takes at least 1 year, he would have found maybe even a better result. But the conclusion was that in the grafted group, there was a slight gain in terms of soft tissue volume. So not only that we don't lose where we graft, we also have a slight gain. So we add up these two numbers, it adds up to 1.5 millimeters. And when we talk about numbers in the aesthetic zone, where 1.5 millimeters can be pretty crucial from an aesthetic point of view. When we talk about what are the options then? Okay, we see that we have a benefit from soft tissue grafting, but what are clinically the options that we have? So the palate is an excellent donor site, and we have different areas to go for, and we have different techniques that we can apply, like a single incision, trapdoor technique. We can go also for the tuberosity areas and so on. If you take a look at these 3 different types of grafts. So we have a free gingival graft on the left side of the screen that has been deepithelialized. We have a tuberosity graft and a subepithelial connective tissue graft that was taken with a single incision technique. And as we can see, they are from different areas of the palate, and they have been taken with different techniques. But what is more striking to the eye is that they also look completely different. Now, if they look completely different, most probably they might behave different also clinically. All of them have specific advantages, and I guess that it's important also to understand their clinical relevance for a specific situation, and I guess it also depends to what we would like to obtain, what is our goal. A very interesting article that was published recently in 2015 by Christina Berg where they showed actually that although we have a big variability when it comes to tissue composition in the palate, just by the technique itself, deepitalized connective tissue grafts will always have a bigger amount of thick connective tissue and less fatty glandular tissues that we are used to see when we take, for example, a single incision subepithelial connective tissue graft. And that just by the technique itself, we can influence the type of tissues that we are going to have at the end, and it doesn't have to do necessarily with the area of the palate that we are harvesting. So very simple clinical example. This was an implant placed by us in the clinic, and the time that Nitzan performed the implant placement, the patient didn't want to perform any kind of soft tissue grafting. And we tried to explain to her the advantages, especially in the aesthetic zone, and what might be also the disadvantages. But at the end, it was up to her to have the final saying, because again, we are not talking here about a biological need. We are talking about decisions for an aesthetic aspect. After a few months, when we were about to finalize the case, then she came to us and complained about the dark shadow that she had in the area of the lateral incisor. At the end, she did agree to go through a very simple and actually minimally invasive approach. It was a tunnel technique with very thin pregingival graft deepithelialized, like Zucchelli described so much, and that actually allowed us to have this type of volume gain. Definitely, when we go to more complex cases that start with a bigger deficiency, then the overall treatment becomes more challenging and a little bit more complicated with different steps that are involved. So, for example, we had a patient coming to our office, and his desire was actually to achieve the same appearance on his right side of the arch as he has on the left side. And we tried to explain that in order to do that, we will have to go through several surgical interventions. There's no other way. So we had, first of all, hard tissue deficiencies to start with, and this was the first step that we approached. So we performed a GBR with bone substitute membranes. This was a highly cross-linked collagen membrane. And then later on, implant placement, at the stage of implant placement, the decision taken by Nitzan was to go for one implant, V3 implant, and to go with a Pontic. Because we know from an aesthetic point of view, it is much easier to obtain a better look and position and appearance of tissues when we are dealing with Pontics than when we have two adjacent implants. So the decision was to have an implant in the position of the canine and then a Pontic in the area of the lateral. And after the GBR procedure and the healing and following the implant placement, we only then addressed the soft tissues, because at that time we could analyze what is the deficiency that we have, and that will allow us to decide for which type of connective tissue graft to go. So we had actually two stages, one at the implant uncovering and the second one later on, in order to increase even more the volume, especially in the area of the Pontic. So this is actually a small clip from that procedure, and it was a technique similar to the Vista technique. It was a vestibular incision that allowed me to create a tunnel with very thin and microsurgical instruments that gently just raised the tissues in a partial thickness flap type of design that will allow us to slide in later on the graft. So as you can see in the left side of the screen, we have the clinical situation after the GBR and the result immediately after the surgery that we are just watching. Because we wanted to have a stable type of tissue, we went for the tuberosity. We know that these type of grafts shrink very less in time and have different properties even. So we just slightly push it into the tunnel that we just created. And because they are very dense connective tissue, they have to be covered by our flap. So these are the type of grafts that we need to know also how to clinically handle them, so that we will achieve at the end a very good healing. And then we recontour our provisional restoration, screw retain, as we can see here, and we will discuss about this later on, about the importance and how we are going to proceed. So we can see these are the different stages, at the D0, after the GBR, and then after the connective tissue grafts, and we can see very nicely the change in the contours of the ridge from where we started and where we arrived. And if you take a look from an occlusal view, we can perceive even better the amount of volume that we were able to achieve. First of all, with the GBR, and then with the soft tissue grafting, in order to be able to provide for their patient the result that he desired. Now, as I mentioned, these type of grafts tend to have sometimes a hyperplastic response from a clinical perspective. This is something that is important for us to know whenever we are choosing to go for this type of approach. And there are many clinicians that report about this type of reactions after connective tissue grafting with tuberosity, from the tuberosity area. Now, when we discuss about the designs of our ceramic restorations, when it comes to implants, we hear a lot saying, well, it should be under contour, it should be over contour, you should add here or remove there. But specifically, if we would have in a didactic way to describe what are the areas that we discuss, I liked very much this article that the group of Ernesto Lee published in 2010. So they actually split the restoration in two main areas. So they define the 1 millimeter that is close to the soft tissue margin as a critical zone. And basically everything that is behind this area up to the implant head has been called a subcritical zone. Now, the first time I talked with Nitzan about this concept, he came to me and he said, listen, well, everything is critical in dentistry. There's no such thing. But I think it's a very nice way to, let's say, understand each other when we are talking about modifications that we would like to perform to our restoration. We can call it in different ways. We can call it superficial zone or deep zone or whatever, but it's important to understand that it relates to completely two different parts. So basically the critical zone, that 1.5 millimeter, has a clinical impact. And I think this is even more interesting, and you could say, okay, what is actually the relevance? Okay, there might be a 1 millimeter margin, but how does it have an impact on my clinical work? Well, it actually, depending on the contour of this area, we will have a control on the gingival margin levels. Then we can decide for the so-called zenith position, and accordingly it will have an influence on the crown shape and length. As I mentioned, everything that is below that to the implant head is called the subcritical zone and has a more or less impact on the interdental papilla, but this is less important. What is more important is that it can have different shapes. It can be more concave, as we see here, it can be more flat. And as this has to do, of course, with the amount of tissues that we are having buccally to the implant positioning and so on. But overall, the tendency today actually is to go for a narrow cervical design, meaning that everything will start from the implant head in more narrow, and then it's going to diverge towards the soft tissues, and that will depend, as I mentioned, on several also other aspects. So if you take a look occlusally and try to understand what are those areas that I just mentioned clinically. So we have a subcritical zone, as I mentioned, from the implant head, very close to the gingival margin, and then we have the so-called critical zone, or superficial zone, that is immediately related to the gingival position. Now, as you notice clinically, when we are grafting and we are talking about volumes, we mainly relate to the buccal aspect. It's not so important to us exactly how thick are the tissues, because in the palatal area, in the majority of the cases, we will not have problems in terms of volume of tissues. Now, related to the timing of our clinical procedure, there is an influence towards the design of our restoration, and this can be provisional or definitive. And what do I mean by that? If we have a provisional restoration, and we have performed an immediate procedure, like an immediate implant and immediate soft tissue grafting. So the soft tissue will have basically a function of support, and we will go more in details regarding that. When we have can be a provisional or definitive restoration that is inserted in a later approach, when soft tissues are already matured, then we can call it their influence, let's say, the soft tissue manipulation, because we can guide and influence the contours and the soft tissues with our restoration. So as I said, if we have, let's say, an immediate case that we immediate extraction, immediate implants and loading, in this case connective tissue graft was performed in this situation, a subepithelial connective tissue graft. So the contours of the restoration will be away from the soft tissue, let's say. So the influence will be just in giving support, but there will be no compression. There will be no pressure in those areas. And we discussed that on teeth. And why is this important? Because we know now that every time we are going to apply pressure on the tissues, we are going to trigger a vascular response. We are going to actually provoke ischemia. Now, for any type of regeneration procedure, the presence of blood is actually the most important thing. This is what we would like to have. So in order not to influence or interfere with the proper initial healing, we would want to have any kind of influence on those tissues at that time. The situation changes when we have tissues, as I mentioned, that are already matured. For example, in a late approach, and we we can actually manipulate the position and the contours of the tissues, because we know that these tissues being mature, they will be able to withstand the changes that we are trying to imply with our ceramic restoration. And then this again, it can go for provisional, but as well as for the definitive stage. So mainly these are the two important aspects that we'll have to remember, that a soft tissue support will be anytime that we are performing a kind of regeneration procedure. And later on approach, we can talk about soft tissue manipulation. We can talk about changing the positions and the contours with our restoration. Now, clinically, this is how it looks like. So anytime, like in this case, a soft tissue grafting has been performed, the provisional restoration will not be an aesthetic one, and the patients are being informed about that. So whenever a tissue overbuilding, let's say, has been done, the provisional restoration will have to be under contoured at these stages, and the patients will be informed that at this stage they shouldn't expect for aesthetic result. The aesthetic result will come only towards the finalization of the treatment, and this is a compromise that they have to know ahead. So when we were close to the finalization of this case, this is what we see. We have the implant abutment on tooth number 11, on the area of number 11, and then we had the adjacent teeth that had to be restored. So we see that there is a difference in the position of the soft tissue margins, but this is what we would always like to have around implants. We would like to have as much as tissues as possible. But that means that in order to achieve a harmonious, let's say, harmonious, not integration, but appearance of the two centrals, the changes in the positions of the soft tissue will have to be performed with the help of our ceramic restoration. In this case, we collaborated with Vincenzo Musella from Modena, and he prepared for us, in this case, 3 ceramic veneers, and as you can see, the design of the implant abutment is also as a prepared teeth. The reason is that it is much easier for the dental technician to control the optical effect of the final restoration when he is working in the same thickness. So for him, at the end, he will have 4 ceramic veneers with same thickness, because he will design the implant abutment in such a way that will be similar to the preparations of the natural teeth. And this is the time of insertion. We have a critical zone that will give the position of the gingival margin, and it will also be influencing, as we understood, the shape of the final restoration. So at the end, what we have a one-piece crown, and this is the 1 millimeter part that I was mentioning about the critical zone. And when we insert, you can see immediately that it determines actually the reorganization, let's say, of the tissues in this area. And around implant restoration, we are lucky compared to lateral dentition, because if we perform soft tissue grafting, we can have a sufficient amount and thickness of connective tissue to play with and to really obtain at the end a natural, pleasing result of the final restoration that is in accordance to the adjacent teeth. Now we are getting close to the end, and I would like to take you briefly to a clinical case, a pretty complex clinical case that will emphasize also the complete workflow. So we have a questionable number tooth 11, some uneven gingival lines, we have all deficient restorations, and we have also some periodontal problems. And this is a patient that needs untreated some, I don't know, 15 years ago, I guess that was. I saw the patient around 2015 when she already came with a hopeless central incisor that had to be removed. And after an intense discussion about what would be the best treatment choice for her, we decided to go for single unit teeth. That meant that this hopeless tooth will have to be replaced with an implant. So a fixed partial denture was taken out from the treatment plan. We looked at the CBCT and we decided to go for a staged approach because we had several issues. We have a hopeless tooth in the smile zone, which we know it's one of the most, let's say, challenging treatments that we can perform, giving also the psychological factor of the aesthetic area. Then we have deficiencies present that are not only related to hard tissues, but also to the soft tissues. We'll have to decide for a mediate, delayed, or late approach, and as I mentioned, we prefer to go for delayed. And then there was an issue about the teeth form and size. It was a very interesting case that we did with the visagism technique, but of course we don't have time to go into details regarding that. So following our main complaints and problems, we will go towards the treatment plan steps. So we will have single teeth, as I mentioned, was one of the things that the patient insisted on. So tooth 11 will be extracted. A rich preservation approach will be performed at this stage. Late implant placement and minimally invasive surgical techniques, as I mentioned, they are always in the background of our mind. So I used the ice cream cone technique that was published by Tarnow and Elian and his co-workers, in which when we have a deficiency of the buccal plate, we use a collagen membrane without raising any flaps, so nothing is meant for initial healing or everything for secondary healing. Bone substitute was inserted into the extraction socket and everything was covered and left for secondary healing. And again, the same concept of how do we contour our provisional restorations, where again, it's about support and not to compress, not to interfere with the initial healing at this stage. Then we waited around 7 months, and you can already emphasize from this image that something else had happened. So when you always prepare for everything, then you have the unpredictable coming. So we had to reset our goals, because what we used to have a delayed approach with only one side to address, now we are going to have not only a late implant placement in this area, but we are going to have also an immediate implant placement in the area of the 22. Of course, from the beginning, it's easy to understand that whenever you are dealing with a situation that you have intact supporting structures that are bone and soft tissues, you would be clinically much easier to handle and control all the factors that will allow you to achieve almost perfect result. So we had completely different situation. This is the time that we were preparing for extraction and implant placement. And I don't have time to go into details on how we planned it together with Nitsan, which we inserted these two V3 implants. As we can see, we had, and we knew it from the CBCT, that we might have some areas that the threads will be exposed. And we see beautifully here the distance and the relationship of the implant with the buccal plate. Then we aim to perform a GBR in the area that the threads were exposed. this can be interesting for discussions, whether soft tissue would be enough, like Zucchelli talks a lot about it recently, or not. But we addressed the filling with bone particles and membrane only in the area of the area of the implant in the position of number 11. We just filled in the gap between the buccal aspect of the implant and the buccal plate, because we know a big part of this bone will resorb during the healing. And then PRF, because we believe in a very good initial healing, especially when we are performing this type of augmentation. And then I have again a waiting period. And at the uncovering stage, we are trying to understand now what will be actually the deficiency that we are dealing with. And according to that, we will establish what will be our aim, or what we would like to gain basically from the soft tissue grafting, and what type of connective tissue graft I would like to have. So at that time, I also took a digital impression, because we wanted to provide for our patient the next day with a provisional restoration that will be based not only on the teeth but also on implants. Then the approach was to go very minimally invasive, just to increase the volume buccally and to the base of the papilla with this type of microsurgical instruments that allow us to create the tunnel, the pouch, where the connective tissue graft will be inserted. Then I went for the palate, and lately I like very much to take this type of connective tissue grafts, because they are dense connective tissue. I see very limited dimensional changes in time compared to the more fatty glandular tissues that we used to insert with the single incision approach, for example. And then according to the size of the deficiency that we had, we chose the dimension of the two grafts. As we can see here, in much bigger dimension for the area of the delayed, because there we wanted also to give support for the base of the papilla. So it's not only to augment the soft tissues in the middle part of the implant, we have to give support interproximally, because this is going to be the seed for the future papilla, if we would like to have one surrounding our restorations. So the volume is not only buccally but also towards the interproximal area. So this was actually the profile immediately after surgery, and we see we change the contours of the ridge from something concave to something convex, because that will allow us later on to be able to manipulate them and to design them with our ceramic restorations. So based on the digital impression that we took, Yuli Cooperstein provided for us CAD/CAM milled composite restorations. These were TeleoCAD. And another important stage that also reflects the importance of the communication. We emphasize to our technician that this is an area that just received soft tissue grafting. So we don't want him to create the perfect contours for these restorations. We are not interested in that. We want to give tissue support, and that's it, related to the volume that we were able to create. And this is not the stage where we're going to try to manipulate the tissues in any way. So what do we have? We have the critical zone, that 1.5 millimeters, and we have again the subcritical zone up to the implant head. So we will try to stay narrow in this area, because we already augmented the soft tissues, and also not to compress it in the critical part where the soft tissue margins are. Clinically, this is how it looks like at 8 weeks. And we see that we have a lot of advantages with this type of implants that allow us actually to have more, not only bone, but more tissues exactly where we need it, especially in the aesthetic zone, which is actually buccally to the implant. So we were able to create nice contours and obtain a sufficient amount of volume of tissues that can later on provide us the base, the foundation for the definitive restoration. Now, unfortunately, we work digital until now, and we move now to the analog route, because Stefano, which was the technician in this case, is still not, but hopefully very soon will be more into the digital approach. But that is not a big problem, because the concepts are the same, and their implementation is as important. So what does it mean now? It means that actually the ball is in his court. He will have now an original model that represents actually the clinical situation that we have in our patient's mouth. But we have, as always, an ideal wax-up that emphasizes what we would like to achieve. So he will actually transfer from the ideal wax-up to the working model, the gingival line. So we will have on the ideal model, he will mark where the soft tissue positions we would like to have them around those teeth. He will transfer them with the silicone index to the working model, and he will see very clearly how he needs to design and recontour those restoration in order to obtain that final shape and profile. So actually he's redesigning everything on the model. So the cervical contouring concept is actually a model-based concept. So he's going to remove, in this case, a little bit too much from the subcritical zone, let's say, because that is the area where we augmented. So if I was able surgically to obtain a big amount of tissue in terms of volume, definitely I don't want it to be carved away from the model, because that means the moment I am inserting the restoration into the patient's mouth, it's going to compress the tissues for no reason. But he's going to redesign the envelope not only on the area of the implants, but also in the area of the supporting teeth. So as I mentioned, this is the model-based cervical design, but it's based on the cervical contouring concept published in the same year for implant-supported restoration in 1994, as it was for natural dentition. So again, we come back to the same idea that is being implemented in a different way, but we need to understand the biology in order to be able to control and not to cause any irreversible damages to the periodontal structures. So we have an ideal gingival profile based on the cervical contouring concept that relates both to the natural teeth as well as to the implant-supported restoration. So we will have a hybrid type of crown, as we can see here, with the zirconia core. On top of that, we will have some ceramic in order to obtain a true adhesive bonding between the IMAX, the lithium disilicate 3/4 veneer, and abutment. And then we have to follow the adhesive bonding protocols. I mean, everything that we have done depends also on the last stages when we insert and bond the ceramic restoration. So we condition and we follow the strict protocols of the company that provides for these specific materials, because different type of ceramics will have different type of protocols in terms of how to condition and how to adhesively bond those restorations. So this was the final screw retain restoration that we inserted on the area of the 11 and 22, and this is only 1 week in function, and we can see clearly that the tissues will start to adapt around the new contours that we have of the ceramic restoration. We can still see here a little bit part of the soft tissue grafting, the area that was grafted, and we are waiting actually for maturation. As we can see, this is a 2 years. We are actually close to 3 years of follow-up of this patient, but this is a 2 years image picture, and we see it's not a completely perfect result, but I think it can be very satisfactory given the fact that we started with such a deficient situation in the area of the 11, but look how beautifully we were able to reconstruct everything, actually better to say maintain everything that was already there, and it is much more difficult to control several aspects when it comes to regenerate, let's say, to reconstruct something that was already lost. When the patient smiles, we see a beautiful integration between the lips. There are no black triangles, which is usually what patients complain when we are missing papillas around our implant restoration, but it's less noticeable to her that she has less volume in the area of 12 and 11 that she has on the left-hand side. But this nice integration, not only you can see clinically, but also radiologically, when we look at the x-rays of the area that were augmented, and also from an occlusal view. And the reason why we like very much to take these images is not only because we enjoy looking at beautiful pictures, but it actually shows this magnification and this magnitude really response of the tissues to whatever we are doing clinically. I mean, there is no better control and no better way to judge our results than really increasing these images and looking at the responses to whatever we have inserted. Now, a few guidelines to follow, although there is, I mean, there are no cookbooks or no things that can be said and then followed accordingly, because the oral cavity is a continuous changing environment and each and one of our patients is different. But overall, when we talk about the things that we would like to have in mind is that we should establish a proper and, more important, it's efficient communication. It's not only the when we talk, but it's also the way that we talk and the way that we are able to transmit the important information between the different team members. So it involves an interdisciplinary, of course, approach between us as practitioners, by the patient and as well as the dental technicians. So it is about the team. It's not about the singular individual like it used to be in the past. We should analyze each case in depth, and that means planning top down. I think that I was pretty clear that we try to have the end result in mind at the beginning, because we would want to understand the expectations of the patient and to see if we can really fulfill them with our final design. It is important to try to control each treatment step, but as we saw, as much as we are prepared, we are never prepared for the unpredictable. We try to understand and respect biologic principles because this will never change. Materials might change, by the way, techniques might be changed, but the way that soft tissue responds and the way that biology acts, it will always stay the same. We try to preserve and augment whenever we have deficiencies, soft or hard tissues. We'll try to aim for at least 3 millimeters, and it's not that important, I think, today of the percentage or the balance more towards the bone or towards the soft tissue. It should be an overall 3 millimeters. And we try to stay minimally invasive with our procedures, and that goes both for prosthetics, but also when it comes to the surgical approach. We should try to take into considerations also that we have a human being in our chair and try to minimize whenever we can, if we can, the invasiveness of our treatment. And with this, I would like to thank you very much. I hope I was not a lot over time. I was a little bit. But I hope that I was able to send you, let's say, a message that we try to implement it in our daily clinic, that is based on the results that we obtain by having such an approach. I don't know if there are questions, or if there is. I see we have some questions. Okay, what were the fifth phase in the treatment sequence? So, I mean, the fifth phase, I said, it is maintenance, and this is very important because it doesn't matter at the end how much you invest in your surgical techniques and augmentation if the patient cannot maintain a very good oral hygiene. So having actually the patient comply towards the treatment already from the beginning, that should be a question mark. So if somebody cannot maintain a very good oral hygiene, many times we will not proceed with the treatment, because that means that he will not be able to maintain whatever we are trying to provide for him. Okay, next question. Valov. Hi, Valov. How long the temporary crowns stay before applying the final ones? Well, that depends. So, for example, if we have undergone any kind of periodontal surgeries, like crown lengthening, or there are some periodontal involved teeth, we have to wait for maturation of tissues. And in order to have that, we have to wait at least 6 months. But we know that sometimes it might take even up to a year in order to have a final position of the tissues. Now, when I talk about natural dentition, in order to go for the finalization. Of course, there are cases that, like for veneers, when things are more straightforward and preparations are supragingival, so there is no health problems to take into consideration, then there is not a matter of time that should be taken into consideration. When we talk about implants, well, that depends also on the case, but I guess your question relates to teeth, if I'm not mistaken. Still from Valov, when we have over contour crowns, do we do new ones? Well, when you have an over contour crown and you already cemented and you didn't notice, then I guess you will see it only in a while when you will have a soft tissue response. Now, that depends on where is that crown position, how well your patient cleans, and if in an aesthetical area and your patient complains, well, then there's no other way to go for. Usually that happens, I guess, when you have a soft tissue biotype. So if you don't want to change the crowns, you might take into consideration some soft tissue grafting and increase the thickness of the tissues, and that might be also an option. Shall we tell the technician for the type of biotype? Well, definitely. I mean, the technician will understand it anyway once you send the impression and clinical images, and he will always design the positions of the soft tissues, and according to that, so he will build in wax on the model how he will want to have the contours of the tissues, and according to that he will have the design of the ceramic restoration. So it's something that your technician, it doesn't matter if you tell him thin or thick, he will have to analyze it by himself on the model. So it's part of his decision and his workflow. Ascensio, what type of cement did you use for the crowns and veneers? It was Variolink Aesthetic, Light Cure LC for the veneers, and Dual Cure cement for the crowns. You can use also Panavia, but usually for the veneers we go for the aesthetic, the Variolink Aesthetic. What kind of membrane did you use in the last case? As I mentioned, it's a highly cross-linked collagen membrane. It's called O6+. And the advantage is that it really, let's say it has a very long term until it actually resorbs. And many times when I was performing on covering after, or time of implant placement after big GBRs, I could actually see my membrane present at that time. So I can really rely that it's really a true barrier, and we get excellent clinical results with this type of material. What kind of bone? Well, we usually use a combination today, but it depends again on what is the clinical situation. For that case, we had a combination of cenogenic bone that was Bios and an allograft, which was Minerals. Which slightly changed our approach today. So if it will be a bone augmentation with the same time with implant placement, and I would like to cover threads that are exposed of the implant, I would go for autogenous bone, for example, just scrap it from the area from close to the implant and have that on the buccal side of the implant or close to the implant, and then augment with a cenogenic type of material, just because I want to have something that it's stable and it will not resorb in time. So it's because it's all about volume. So where I care about biology, I would go more for an allograft or autologous bone. But when it comes to stability, which is what we would like to have in the aesthetic area, I would go for a bone substitute that I know it has very limited resorption time, almost none, like cenogenic material. See you in Bahamas. You're right. Thanks so much, Valo. I hope you guys got some ideas, and I hope that I was more or less clear, although we had 1 hour, but it was important just to emphasize that basically how one clinical concept can be applied both on natural dentition and implants just by understanding the reasoning. Thank you all. If there are any more questions. I'm very happy, Val, of your coming to Bahamas.